By the time most people reach their mid-50s, the soft tissue of the midface has descended between 8 and 12 millimeters from where it sat at 30. That number comes from imaging studies measuring anatomical landmarks across age cohorts. It's not an estimate. 8 to 12 millimeters is roughly the width of your thumbnail, and it happens across approximately 15 years. Cosmetic medicine calls this ptosis. The rest of us call it the jawline softening, the jowl appearing, the heaviness settling where there used to be definition. The standard explanation is collagen. Collagen production declines, the scaffolding weakens, gravity wins. And that explanation is correct, as far as it goes. The part it doesn't explain is why two people with nearly identical collagen profiles, identical sun exposure histories, identical weights, show dramatically different rates of descent. One face holds its structure well into the 60s. Another softens noticeably by the mid-40s. The same biology, different outcomes. That gap in the explanation has a physical cause. And the physical cause has a specific location. It is not in your face. It is not in your neck. It is in the soft tissue behind your knee. Press 2 fingers into the crease at the back of your knee right now if you are sitting. The soft hollow there, the popliteal fossa, is where a significant piece of this story lives. Most people have never thought about that tissue in relation to anything north of their thigh. That is precisely the gap we are going to close today. There is something pulling on your face that nobody has named for you yet. By the time we finish, it will have a name. The body is not a collection of independent regions connected loosely at joints. That model, the mechanical parts model, the idea that your knee is a knee problem and your jaw is a jaw problem, was useful for surgery, but it was never accurate for understanding how the body ages. What anatomy has established, particularly over the last 30 years, is that the body is wrapped in a continuous web of connective tissue called fascia. This tissue surrounds every muscle, every nerve, every organ. It connects structures across enormous distances, and it transmits tension. This last point matters more than any other. Fascia transmits tension. A restriction in one area is not merely a local event. It creates a pull, a drag, a loading pattern that travels through the continuous sheet. Thomas Myers, whose work mapping these fascial lines over decades produced the framework known as anatomy trains, described the body as a system of tensioned cables rather than separate compression columns. Under his framework, which has now been extensively validated in dissection studies and clinical imaging, the body has a small number of primary fascial lines that organize movement and transmit load across the full length of the body. The one relevant here runs straight up your back. It is called the superficial back line, and the posterior knee sits directly on its path. The superficial back line begins at the bottom of your foot, specifically at the plantar fascia, the tissue under the arch that most people know because it hurts when it becomes inflamed. From the plantar surface, the line runs up the back of the lower leg through the gastrocnemius and soleus, crosses the posterior knee, continues up the hamstrings, climbs the sacrolumbar fascia along the spine, runs over the skull, and terminates at the supraorbital ridge, the bony prominence just above your eyes, and at the epicranial fascia of the brow and forehead. That is one continuous line, from the sole of the foot to the brow of the face. The posterior knee is not a midpoint on this line, it is a junction. It is where the musculature of the lower leg transitions to the musculature of the thigh, and where the fascial tissue crosses a joint that is almost never in full extension during modern daily life. The knee at 90 degrees, the angle of sitting, puts the posterior knee tissues into a state of approximation. The two ends of that fascial section are brought closer together, held there for hours, across years, across decades. The tissue adapts. Dr. Carla Stecco and her colleagues at the University of Padua, whose histological work on fascial tissue has become foundational in understanding how fascia transmits mechanical signals, demonstrated that fascial tissue, subjected to sustained low-load compression, undergoes measurable changes in its gliding capacity. The layers that are meant to slide against each other begin to adhere. Not dramatically, not painfully, not in ways that show up on imaging easily, but the glide is reduced. The tissue becomes what clinicians call restricted. A restricted fascial junction does not stay local. When the posterior knee tissue loses its capacity to glide and lengthen freely, it creates a persistent caudal pull on the structures above it. Caudal means downward, toward the feet. The hamstring fascia, the sacrolumbar fascia, the posterior cervical fascia, all of these are in continuity with the compromised popliteal tissue. The tension propagates. It climbs. By the time that pull reaches the skull, it is distributed across the epicranial aponeurosis, the broad, flat fascial sheet covering the top of the head. The gallia aponeurotica, as it is formally named, connects posteriorly to the occipitalis muscle and anteriorly to the frontalis muscle of the forehead. The temporal fascia attaches laterally. In the soft tissues of the midface, the superficial musculoaponeurotic system, what surgeons call the SMAS, are in continuous connection with this epicranial sheet. So when the posterior knee creates a caudal drag on the superficial backline, and that drag climbs to the skull, the epicranial fascia is pulled posteriorly and inferiorly. The SMAS connected to it responds to that chronic loading. The structures that hold the midface up, not by active muscle contraction, but by fascial tension, are under a sustained downward and backward pull. This is not the only force acting on the face. Gravity acts on the face. Collagen loss acts on the face. Volume redistribution acts on the face. But the fascial pull from the posterior chain is a force that has a specific, addressable, mechanical origin, and it originates in large part behind the knee. This is what Loop C has been building toward. The SBL under chronic posterior knee compression does not merely create tight hamstrings. It creates a whole body postural loading pattern whose facial endpoint is real, measurable, and largely invisible to the standard clinical approaches to facial aging. Now consider the geometry of sitting. When you sit in a standard chair with your knee at roughly 90 degrees, the back of your knee, the popliteal fossa, presses against the seat edge. This is not a catastrophic compression. It is, however, a sustained one. Office workers in their 50s have often accumulated between 80,000 and 120,000 hours of seated time since entering the workforce. That is not a dramatic loading event. That is a slow accumulation of adaptive fascial shortening at one of the most mechanically significant junctions in the body. Think about it the way you might think about a house, and how you'd explain it to someone who'd never thought about structural load. If you ask someone why the ceiling was cracking, they might point at the ceiling. But the reason for the crack is rarely in the ceiling. It is in the foundation, in a load-bearing wall, in a subtle shift in how weight is being transferred through the frame. The ceiling just happens to be where the consequence becomes visible. That is what the face is in this system. It is the ceiling. The loading at the posterior knee is the foundation event. Years of sitting with the back of the knee against the chair edge without adequate posterior knee mobility creates a fascial environment where the tissue cannot fully lengthen. Add to that the second most common sleeping posture in adults over 40, which is side lying with both knees in flexion, often drawn toward the chest. This maintains the posterior knee in a shortened position for another 6 to 8 hours per night. The tissue never fully opens. It adapts to the shortened length. When the tissue adapts to the shortened length, the superficial backline is under chronic caudal loading. There is research from the journal Clinical Anatomy, one of the few journals that publishes dissection-based fascial studies at scale, documenting that sustained low-load fascial compression, as brief as 20 minutes, can initiate measurable changes in fascial hydration and gliding capacity. That is a 20-minute sitting session. Most of us are not sitting for 20 minutes. We are sitting for hours, then sleeping in flexion, then sitting again. The accumulation is the point. This is not an injury. This is a geometry problem with a decades-long timeline. Here is where my own experience enters this, and why I want to bring it in carefully. I have been working with patients on postural and fascial problems for a long time, and there is a particular moment in clinical practice that changes how you see things permanently. Mine came during a session with someone who had come in for jaw tension, clenching, temporal headaches, the full picture, and whom I had been treating with the conventional approach, which focuses on the jaw and neck. Progress was slow. On the same day, I had been reviewing Meyer's SBL documentation again, and I pressed into my own popliteal fossa as an experiment. The restriction I found there was striking, not painful, but dense, unyielding in a way that a freely mobile tissue junction shouldn't be. I had been sitting at a desk for most of my career. The tissue behind both knees had adapted. I worked on it. Not aggressively, not with instruments, just sustained, gentle manual pressure into the posterior knee tissue. And then I stood up and felt the sensation that anyone who has worked with fascial tissue recognizes immediately. The sense that something long held has been permitted to lengthen. The back felt slightly longer. The chest opened marginally. And there was a subtle, almost implausible sensation of decompression in my temporal region. I cannot offer that as clinical evidence. A single self-observation is worth exactly what it cost. What it did was prompt me to start systematically palpating posterior knee tissue in patients with facial tension in mid-face descent patterns. The restriction is there, consistently, in people who have accumulated years of sitting posture. And when it is addressed as part of a broader protocol, not in isolation, outcomes improve. That consistency is what I am offering you, not a case study, a pattern that clinical practice has made visible. So what do you stop doing? This is a negative protocol, which means the intervention is primarily subtractive. The additions, the releases, the mobility work matter, but they build on the foundation of removing the loading inputs, and those inputs are specific. The first, stop sitting with the back of your knee against a hard chair edge. This sounds trivial, and it is the most consistently overlooked ergonomic factor in the upper body and facial aging conversation. The posterior knee tissue has blood vessels, lymphatic vessels, and fascial layers that are all affected by sustained compression against a hard surface. Scoot your sitting position forward so that the chair seat supports your thigh but does not press into the popliteal crease. Your knee should be able to have space behind it. If you cannot achieve this in your current chair, a lumbar support that tilts your pelvis forward will often change the contact geometry sufficiently. The second, stop sleeping in full bilateral knee flexion without a bolster between your knees or beneath them. The goal is not to straighten your knees completely during sleep. That is neither comfortable nor necessary. The goal is to prevent the posterior knee from spending 6 to 8 hours per night in a fully approximated position. A folded pillow beneath both knees in a supine position will suffice. A pillow between the knees in a side-lying position slightly opens the hip, which changes the fascial geometry at the posterior knee as well. The third, stop standing with your knees locked into hyperextension. This is a distinct loading pattern from sitting flexion, but it belongs on the same list because it creates SBL tension through a different mechanism. It shortens the posterior knee tissue through posterior compression rather than anterior compression, and it creates a pelvic tilt that loads the sacrolumbar fascia. Soft knees in standing. Not bent significantly, simply not locked. These three subtractions remove the primary loading inputs. The addition that follows, and it is one addition, not 15, is sustained, gentle pressure into the posterior knee tissue itself. Not aggressive, not painful. The popliteal fossa contains neurovascular structures and deserves care. Using 2 or 3 fingers, apply gentle downward pressure into the soft hollow behind the knee. Hold it there. Not for 20 seconds, not for a minute. For 3 to 5 minutes per side. Ideally in a position where the knee is at roughly 30 to 40 degrees of flexion, not fully bent and not fully extended. This can be done seated on the floor with legs slightly bent, or supine with a rolled towel under the knee to hold the angle. What you are doing in that 3 to 5 minutes is providing a sustained low load signal to fascial tissue that has been compressed into adaptation. You are not breaking anything. You are changing the mechanical input long enough for the tissue to begin responding. Research on fascial tissue response times, cited extensively in the manual therapy literature, suggests that fascial tissue requires sustained loading of at least 90 to 120 seconds before it begins to viscoelastically respond. Short interventions, 20-second stretches, do not reach this threshold. 3 minutes does. Do this consistently for 4 to 6 weeks before evaluating. The changes in facial tissue are not the first thing you will notice. The first thing is usually a subtle change in the sensation of your neck and shoulders, a sense of length that wasn't there. That is the SBL beginning to function with less caudal restriction. The facial changes, when they come, are not dramatic. They are the absence of the downward pull, less heaviness, more definition at the angle of the jaw. These are not cosmetic illusions. They are the mechanical consequence of reducing a loading pattern that had been pulling for years. This is what Loop B has been pointing at. The posterior knee is not just a knee structure. It is a facial structure, viewed through the lens of the superficial back line. And this is what Loop A opened with, the thing nobody has named for you. The downward pull on your face has a mechanical source. It has always had one. The source is specific, addressable, and not in your face. The synthesis that closes all 3 loops is not complicated, but it is significant. The face is a readout of the full posterior chain. Every structure below it, the skull, the cervical spine, the thoracic fascia, the lumbar fascia, the posterior knee, the calf, the plantar fascia, is in tensioned continuity with the soft tissues of the midface. When one node in that chain is chronically loaded, the transmission is upward. The endpoint of that transmission is visible. Cosmetic medicine has developed extraordinary tools for addressing the endpoint. And for many people, those tools are the right choice. But addressing the endpoint while leaving the loading source intact is the equivalent of repainting a wall without fixing the moisture coming through it. The result is temporary. The source continues. The strategic approach, and this is what distinguishes a systems level understanding from a localized one, is to address the loading source first, or alongside the endpoint treatments, or instead of them, where the descent is still early and the chain is still addressable through mechanical means. The back of the knee is where the intervention begins. People who understand the body as a transmission system, who recognize that the face is connected to the floor by an unbroken line of tissue, make different decisions about their ergonomics, their sleep positions, and where they spend 3 minutes of focused attention each morning. They are not people who believe the jaw is isolated from the knee. They are people who have seen the map. That map begins, and in many ways ends, at the back of the knee. There is one more thing this opens up that I want to leave you with. Not a protocol, not an instruction, a question. If the posterior knee is a facial junction through the superficial backline, what are the other junctions? The SBL is one of 7 primary fascial lines that Myers documented. Each one has its own compression points, its own facial endpoints, its own relationship to posture and daily geometry. The posterior knee is the most clinically significant one for mid-face descent, but it is not the only one. That question is worth sitting with, preferably with space behind your knee.